I welcome all of you to IBM TV and to this show, which is Dr. Dhawan's live chat, and I'm your host, Dr. Sanjay Dhawan. I'm an eye surgeon practicing in New Delhi. The live chat is a show which talks about any and all aspects of life, any subject, anything that concerns the life or it improves its quality is what we will be talking about. How to plan for it, how to prepare for it. So we'll be talking about all of this. Looking forward to seeing all of you every Friday night, 9:30 p.m. to 10:30 p.m. Indian time. Thank you. Bye-bye. Namaste.
Namaste. Good morning, good afternoon, good evening, depending on wherever you are. Welcome to yet another session of Dr. Dhawan's live chat. In the previous 3 weeks, we have been talking about various aspects of COVID. 3 weeks ago, we talked about the deadly second wave that has hit India in a very, very bad way. Then 2 weeks ago, we talked about how COVID can affect children. And last week, we talked about COVID and diabetes scare. And when we thought that things are easing up, the peak is now flattening, and suddenly we are hit by yet another menace called the black fungus, or technically called the mucormycosis, which is a very, very devastating disease, a rare disease, but a very, very devastating disease, and it's hitting in a very, very big way to various people who are recovering from COVID in India. So we thought, let us talk about this very, very important and vital subject. And to talk about this, I have a few very, very accomplished guests today. And let me call upon them one by one. Dr. Rajiv Gupta, who is a very senior consultant and specializing in internal medicine, working in New Delhi with Fortis Hospital and MD City Hospital. He incidentally has been my teacher from medical college. Welcome, sir. Good evening. How are you doing? So Dr. Rajiv has been my teacher in medical college, and I know from my personal experience that he's one brilliant guy who has such an amazing knowledge of this subject that it is, very difficult to equal. So, sir, thank you very much for joining our show. The second guest is Dr. Ashish Srivastava, who is a very senior neurosurgeon attached to Narayana Dharamshila Hospital, New Delhi. He is again a very, very bright guy, and he's a friend of mine from school. And again, from my personal knowledge, I know that he's actually has sheer brilliance, such a great command of his subject and surgery. So welcome, Dr. Ashish Srivastava.
Thank you.
Hi, Dr. Ashish, how are you doing?
Good evening. Fine, thank you.
Nice to see you here.
Thanks.
The next guest is Dr. Sumit Mrig, who is a senior ENT surgeon and director at Max Hospital, Saket, and who's been actively involved with managing the mucormycosis cases at Max along with my team. Welcome, Dr. Sumit Mrig.
Thank you very much. Thank you.
Hi, Dr. Sumit, how are you doing?
Great, sir. Very well. Just finished work and reached home.
Wow, fantastic, fantastic. We have yet another guest who is part of my own team. He's a very accomplished Oculoplasty eye surgeon, Dr. Rituraj Barua. He's working with me at Max Healthcare as part of my team. Dr. Rituraj, good evening, welcome. Thank you for coming in. I hope your network is working fine now.
Hello. Hello, everybody.
Great. Yeah, so he's been having some issues, some technical issues with the network. So I hope you all accept and pardon that. So let us start with the very, very basic. And I'll start with asking this question to Dr. Rajiv. What is black fungus, or what is mucormycosis that we hear about these days, which is creating havoc all over India?
This mucormycosis is a very uncommon fungal disease. Generally, we see a few cases around the year, but this time, because of COVID and because of some medical treatment as well as uncontrolled diabetes associated with COVID, we see large number of cases coming, and virtual epidemic is to be declared. So it is basically a fungus disorder which belongs to a order of Mucorales, and there are two groups under this, and one of them is mucor. And within this mucor, we include some 5-6 species. The commonest one of this is Rhizopus, which account for around 46% of human infections. The other is mucor and rhizomucor. The other one, there are few is Cunningham infection and Siskin, Scania infection, and one more Listeria. These are multiple types of fungi which are grouped together into this mucormycosis. Depending on the geographical area, depending on the season, depending on various other factors, you may have predominance of one type of fungus. Particularly in northern India, we see more of Rhizopus or Rhizomucus. Mucor and Rhizopus, these are common variety that you see in northern India. Now the sporangiospore, which are the reproductive organs, are black. They're black color. So once they attack the tissues, they produce sporangias, which are black colored. So the entire shape color of the fungus is black, as if it is studded with black dots over it. Plus, there is a lot of necrosis, and that also gives a black color to the tissue involved. So that is why you call it black fungus, because of these two reasons. Now, this is a devastating infection, particularly immunocompromised host. As we see in COVID, there's a lot of immunocompromising states, either because of disease or because of drug that are being given to tackle the disease. So we see large number of these cases, and we are going to see much more devastating consequences of these cases, including deaths resulting from this.
Yeah. So in a nutshell, basically for the sake of audience, let me summarize it. It's basically a fungal infection caused by a known fungus, which is not new to us. However, it has come to us right now in a very, very big stage. So what is new now? I mean, we've always known this infection to occur, but what is it? What is new now that's coming up in a big way? Last wave in last year, we did not hear much about it. We have not heard about this from West or from America, but certainly it's hit India in a big way. So, what is, in your opinion, are the reasons why it's happening in such a big way, in a bad way now?
See, if you see historically also, we report large number of cases as compared to rest of the world. India in particular, but Asia in particular, we report much larger number of patients as compared to rest of the world. So we do have large number of cases. Now this occurrence relates more to some activities like excavation of soil. This is a ubiquitous fungus, which generally you see on decaying organic matter or soil or animal excreta. So those are the areas where it is growing. So whenever there is a human activity like excavation and construction activities going on, sudden rise in the number of spores resulting in more cases occurs. Now, second thing is a substrate, which is an immunocompromised state. Whenever there is immunocompromised state, for instance, like COVID, more importantly, following say acute treatment of acute myeloid leukemia, you get chemotherapy, post-chemotherapy, there is immunosuppression, organ transplant, hematological malignancies, and there is chronic renal failure, post-tuberculosis. These are the states where you are having a substrate for development and for assault by this fungus. So now, since we have COVID, and in COVID, there is a immunocompromised states in COVID. Third week of COVID is an immunosuppressant stage or immunoparalysis state. Now, besides, you have excessive use of corticosteroids in these cases, and of course, the most common condition, underlying condition, is diabetes mellitus. So, uncontrolled diabetes mellitus, either aggravated by overuse of steroids, is a major factor which is probably resulting in an outbreak of this particular black fungus.
Great. Dr. Ashish, do you have any view on this aspect, that why is mucor happening more commonly now at this stage in India than in the past?
You had the pearls from Dr. Rajiv, and a teacher always tells you the right things.
Yeah.
Why we are seeing it more now, that remains a very rather $1 million question. But thing is that there are 2-3 things which one should sort of consider before commenting on the incidence. We have always had diabetes. We have always had patients with chemotherapy. We have always had immunocompromised patients because of other things. The blast of mucormycosis, which we are seeing in the current COVID phase, was never there. And as Dr. Gupta pointed out, we in India and Asia and humid climate countries and areas, we have always had a higher incidence of mucormycosis compared to the dry areas or the cold areas. So what has happened this time? I think a number of factors which nobody can pinpoint as one reason. High doses of steroids required or inadvertently given to a patient have led to an immunocompromised state. Diabetes has been playing havoc with patients who had COVID infection, because physicians are telling me that they are seeing figures of 450 sugar, 600 sugar, 350 sugars in patients who were well controlled before or were not even diabetic. So there's something going wrong with blood sugar control, and I'm sure the physicians are taking care of it, but it is overwhelming, I must say. Thirdly, does corona itself produce an immunocompromised state? That also is a question which is being considered seriously. For all you know, the virus infections, we know viral infections can affect the various cells of the immune system. So is it the corona itself which is causing the immunocompromised state, or whether it is the steroids, which of course were life-saving, but then the dosage was required or given was probably riddled with this complication. So we are seeing more and more of black fungus or mucormycosis in this COVID phase, even more than what Dr. Gupta said. We find more in Asia and Southeast Asia and Indian continent. So there's something which is working. One discussion which we have been having, and I'm sure Dr. Gupta will, and Dr. Mrig and Dr. Rituraj and you yourself would have seen in COVID, is there was a desperate need for oxygen supplementation. And not everything could be completely given with medical oxygen. Oxygen is oxygen. It is sterile in itself. It's just a gas. But problem is there can be a clean gas and a contaminated gas. So the major source of oxygen became industrial oxygen. So in the industrial oxygen, a few particles of dust or few particles or hyphae of fungus or something, they would not matter. Whereas if they are given to a person who's immunocompromised on high doses of steroids or diabetic or otherwise, and you land them directly on the moist mucosa of the rhinopharyngeal area, did that increase the incidence of fungus affecting the rhinocerebral and rhinopharyngeal area? That could be one of the reasons. Of course, this remains a hypothesis, but that's one source where it could have suddenly, so many number of patients developing it. That's just a conjecture on a lot of doctors' part. And so basically immunocompromise plus maybe some external source like the industrial oxygen.
Regarding the oxygen point, it's seen that most cases have been reported, the ones are from the hospitalized environment. People who have been to the ICU or people who have been on ventilators. So more cases are like that. There are lesser cases who were treated at home and developed mucormycosis. So they have been cases. There have been cases who were never given steroids, who never had any diabetes and or never had any oxygen, still landed up with mucor. So there is some other factor which is probably over and above these factors. But Sumit, it has been actually, even in the media, being talked about the term misuse of steroids. And
Yes.
steroids are being given excessive importance to the causation of this fungus. Do you agree with that, or do you have a different theory of your own?
See, just to give an overview after Dr. Rajiv Gupta and Dr. Ashish sir has given, we have seen an increase in the number of cases of mucormycosis in the last 1 week. And in the last 1 week, I have operated about 14 patients, and 14 have been debrided in the last 3 days. In fact, we started seeing these patients about a week back when there was a panic. There was a little bit of panic by the media, and then the people started, coming to the OPDs. So it's little early to say, but then I am the national coordinator for the mucormycosis from Indian Academy of Otolaryngology and Head and Neck Surgery, our society, and we have just formulated guidelines and submitted to the Health Ministry yesterday. And prelim data, I have a data of about 200 patients from 4 states, North, South, East, and West. And we are trying to study, like what Dr. Ashish and Dr. Rajiv Gupta said, that mucormycosis is not new. It has been in the country, it has been in India for the last 100 years. What has happened in this COVID second wave that we have seen? Steroids were used in the last wave also, but definitely the steroid usage this time was quite unscrupulous. I'll just take 3-4 minutes to explain what all factors. Are steroids really the culprit, or there is something else which we are just not being able to pinpoint? So recent data, what we have studied, about 200 odd patients, About 25 to 30 patients are admitted at Max Saket right now. We have seen an association which I will just share with you. So 80% of these patients are males out of all the 200 patients. About 12% of these patients required some form of high flow oxygen, whether uh, NRBM mode or NIV mode, or they were on BiPAP or they were on ventilators. Not all of them received very, very high doses of steroids. Yes, most of them received steroids, but not like prolonged steroid for about 15 to 20 days or maybe a month. So most of them received steroids for about 10 to 14 days. Then very interesting is that it is seen in most of the states, but Kerala has not seen even a single case right now, till now. Not
No, I'll refute you there. Today morning
so,
we had a conversation with somebody from Kerala. In the
yeah.
last 1 week, they have seen about 5, 6 cases, so it is happening there as well.
So now it must be, but then Kerala was the state where we were not hearing much cases, and there are many theories which are being coming up why this mucormycosis has happened in this wave. Maybe in about when we get a data about 500 patients, we are trying to correlate few factors. So one important thing which I can tell you that the second wave of COVID-19 pandemic was definitely the virus mutant strain was much more severe than it was in wave one. This is something one. Number two, we have seen an association of severe lymphopenia. We are trying to establish a connection that most of the patients whom we have admitted for debridement, or maybe we have done exenteration with Dr. Rituraj, we have seen a severe lymphopenia in all of them. We are also trying to see a correlation between the diabetic status, the sugar levels, their glycosylated hemoglobins, whether they were in DKA state, or we are also seeing the serum ferritin levels. So we are trying to analyze that these 200 patients, if they had some inflammatory markers done during the admission or just during the time of the COVID when they needed admission. So we have seen increase in the levels of serum ferritin. The average glucose level went about 250, 300 in most of these patients. Many of these were pre-diabetic, but they were not aware that they were pre-diabetic. They took consultations on WhatsApp and they took these steroids without the guidance and the monitoring of a diabetologist or a physician. So by that time, when they came to the hospital, their sugar levels were somewhere about 250, 300 or 300 plus. There is also a factor called as interleukin 10, which is actually not being studied in very much detail, but IL-10 levels have also been started to be correlated with the occurrence of this deadly infection. I would agree with what Dr. Ashish has said that industrial oxygen may be a factor. If I talk about Max Healthcare, we have not received any industrial oxygen. If I talk about few hospitals where we have been referred patients, we are taking this consent from them and trying to find out from our fellow colleagues that what kind of oxygen did you get any industrial oxygen supply. So far, I have not been able to see, but yes, we have operated patients from Bareilly, we have operated patients from MP, we have operated patients from Rajasthan, we have operated patients from Punjab. But yes, we can't pinpoint to a source whether the nursing home or a small center was getting supply from the industrial oxygen. Number six, I would say that the low immunity or the immunocompromised status was the single most important risk factor, because in a country like India, where we have a very extremely dry and dusty weather, and these spores, as beautifully described by Dr. Rajiv Gupta sir, they are present in the environment. In the dry and dusty weather, these spores are inhaled through the nasal mucosa, and if there is any aberration in the delicate mucosa, these spores are generally they enter. But with your immunocompetent status, the macrophages and the phagocyte kill them within no minutes. But because of the lymphopenia, because of the poor diabetes, the working action, and on the top, if a patient is taking steroids, the immunity further lowers down, and the delay is there is delay and slow in the activity of these macrophages and phagocytes, that they allow these spores to develop into hyphae. And this is the time when the disease starts with presentation in the sinus area. So definitely there is a correlation with this severe wave, number one. there is a correlation with the diabetic status. We have not even seen a single patient till now who has been non-diabetic and has come to us with mucormycosis. We are doing an Excel, we are doing a record with the Max Healthcare. I am a part of the team with Dr. Sandeep Bhuti, where we are collating data to find out that what actually is the pinpoint cause. Because my wife is a dermatologist, she's a professor at RML. They use steroids for 6 months, for 1 year. They have never seen such high incidence of mucormycosis. And as rightly said, it has been used. We have seen hundreds and hundreds of patients of solid transplantations of stem cell hematopoietic transplants, but we have never seen such level of mucormycosis, which is spreading in a matter of 24 to 48 hours.
Great. So very rightly pointed out all the factors, and let me summarize it for the sake of our audience that first and foremost, this particular strain of virus is a very deadly strain. It is causing a much more pathogenic changes in the body than we have seen in the past. So probably that is the main factor which predisposes the body for the infection. Then immunocompromised state or decreased immunity caused by whether diabetes, use of steroids is a factor too. But this virus itself leads to a decrease in the or disruption of the immunity, especially the what is called T cell immunity or lymphopenia is what Dr. Sumit talked about. There are other factors which are also there, that this increased availability of iron, increased ferritin level, which Dr. Sumit mentioned, the acidosis happening in the body because of either diabetes or because of the respiratory acidosis. It basically, there are some factors which suppress proliferation of rhizopus. Those factors are neutralized by the acidosis now. Endothelial damage to the blood vessels is another reason. And also the local damage in the nasal mucosa, in the sinus mucosa caused by the virus proliferation itself could probably be one of the contributory factors. So there are multiple factors. What is the main factor? We'll get to know over a period of time as the things develop. Dr. Rituraj, so let us tell us about what are the symptoms with which most people present to us. I think Dr. Rituraj's connection is a little is disrupted. Dr. Rajiv, why don't you tell me as for what symptoms do the patients come in?
See, normally we'd like to classify the symptomatology depending on the organ involvement. The commonest here that we see in North India, particularly in this epidemic, is rhinocerebral form. This is rhino-orbitocerebral form. That is the commonest one. The second was the pulmonary forms, when you have some kind of pneumonia which necrotizes and those things. That is the second form. The third form can be a cutaneous form, and the fourth form can be gastrointestinal form, and finally a disseminated form, which is virtually 100% fat. So these are the 5 forms which generally are described for mucormycosis. Commonest one, particularly in this epidemic period, is rhino-orbitocerebral, where you start with a sinus, particularly maxillary sinus, rhythmoid sinus, and that fungus rapidly invades the orbit, followed by invasion of the basal skull, basal part of brain. So that is a commonest type of thing that is there. The presentations, simply patients start with unilateral headache. It's a very classical presentation, starting with a unilateral headache. In fact, I always ask all my patients about the presence of this headache. The second thing is facial pain. Third thing is a retroorbital pain. Now, these should not have happened in an ordinary case. If they are happening, kindly consider this case having mucormycosis. Finally, a nasal discharge, which could be blood state, the proptosis, the ophthalmoplegias in various forms like lateral rectus palsy or the multiple rectal palsy. Then cerebral involvement, which may cause different type of presentation of paralysis, sometimes even stroke-like presentation, because this fungus causes endarteritis or medium-sized vessel. So stroke-like presentations that can also present. And sometimes there is discoloration of the cheek. If it is late, you can have black discoloration of cheek or palate. Hard palate should always you look carefully. There can be black spot appearing on the hard palates. So these are a few common presentation. Proptosis, that eyes start bulging, but they are late sign. That lid, that topsosis, that is dropping of the eyelids. But these signs are late, mind you. Pick them early before it's too late. So earlier signs are yes.
Are there any recent reports of other forms of mucormycosis happening, like gastrointestinal or disseminated or dermal one?
No, gastrointestinal forms are generally in infants and malnourished people. that is reported elsewhere, not in this. I have not seen many of the infants. I am not able to comment on this part, but they were generally earlier seen in premature infants, in particularly. And the other form is pulmonary form. Sorry.
Yeah, yes, please go ahead, sir.
Pulmonary form you would see more in patients who are undergoing chemotherapy for, say, acute myeloid leukemia or organ transplant. Those people develop more of pulmonary form. There is a lot of pulmonary pneumonia, infarctions, nodules, mass-like things. That occurs more in those people than in this situation, as you see.
So
now.
why is it pulmonary form not happening here as much as the rhino-orbitocerebral form?
This is a little difficult. Maybe, see, this fungus resides in sinuses. Mind you, this is airborne. The thing is airborne. The sinuses are first to filter whatever comes through the air, through the nose. So sinus acts like filter. So these spores are generally trapped in the sinuses as a first priority. These are the area where residing most of the time. In fact, they are residing in the normal individuals. This may be called commensal for that matter. And once they get an opportunity to invade, that is what is happening. Once they invade, they start from the sinus. So they start from those maxillary sinus or ethmoid sinus.
Yeah, so this is a very, very intriguing fact that in this particular time, actually it's been declared an epidemic now and it's become a notifiable disease. But it's affecting only the sinuses, the paranasal sinuses, orbit, and the brain. Lungs somehow are not reported as commonly. Dr. Ashish, have you heard of the lung cases of mucormycosis in these days?
Not to my knowledge.
Yeah.
Not to my knowledge. I have primarily seen orbitocerebral kind, which Dr. Gupta has mentioned.
Yeah.
I have seen one case of extensive involvement of the brain by way of a temporal lobe involvement in the pole and a deposit on the brainstem, which is one of the rarest forms to be described for mucormycosis. Involvement of the brainstem is like, it's very rare. So I have, to my knowledge, pulmonary forms. I mean, I'm sure my pulmonology colleagues would probably see much wider range of things, but I have not heard even them talking about a pulmonary mucormycosis.
And any reason why you subscribe to that patient who you saw this brainstem involvement?
I see the problem with the brain and the skull is that it's a very protected compartment. We are very safe. We are affected least, if I may say, compared to the rest of the body.
Yeah.
And the access is only through three routes. One is that there is a direct trauma with a compound injury where the fungus can enter and for any reason it grows. That's the simplest, brainless thinking that there's a trauma, fungus enters, you have infection, you allow it to grow, and then that happens. The second is, of course, the entry from contiguous structures, of which the orbit, the sinuses, any mucosa around it, basically moist mucosa, which can harbor the fungus. So it is from those that we get the cerebral forms. And the problem with this particular and as any fungal infection which we have seen in the past is that these fungi, they tend to catch hold of the blood vessels, leading to vasculitis. Vasculitis leading to local necrosis of tissue, which instead of the decaying organic matter outside the body, the decaying matter in the body. So the fungus starts growing. Now, second thing it does is to erode the bone. And you know very well, all of us, you know it from your eye side, Dr. Mrig knows it from the ENT side, Dr. Gupta knows it from overall, that the cribriform plate, which is just adjacent to the orbital as well as the PNS area, that's a thin bone, sometimes deficient as well. And it is surrounded by ethmoid sinus, sphenoid sinus, and frontal sinus and whatnot. So the barrier between the normal in normal people is bony, it is thin, but in a patient who's got a fungal infection, this barrier goes, and that's most likely where the fungus grows, inside the brain. Of course, in drug abusers, injectable drug abusers, direct hematogenous spread can happen, right? But that is not with the case with COVID patients. Or the current epidemic of mucormycosis, unless you want to blame needles and all. But most of these patients are in standard hospitals under the care of very competent doctors. So I don't think we'd be having used needles and all. So the only reason which stands as the most important is the orbitorhinocerebral route invading from below.
Right. So, Dr. Sumit, what are the other signs
Yeah.
and symptoms of presentation of this? In fact, you see, it most commonly it presents in the ENT. So what are
Yeah.
the signs and symptoms?
See, as pointed out by my other speakers, very rightly, I would be, I would give you a very holistic picture. You know, uh, 13 cases we have operated, three had to undergo orbital excentrations. It means that by the time they presented to us, and as examined by our colleague Dr. Rituraj Barua, the call was that this eye cannot be salvaged, and eye involvement, especially the orbital apex, means you are just sitting close to the cavernous area and to the brain. Rest nine of them, sorry, 10 of them, four we could catch at a very early stage where the symptoms just started. In fact, there were very interesting symptoms and signs which we were able to elicit in few patients.
You need to unmute yourself, Dr. Sumit. You still mute. Unmute your mic, please.
So can you hear me?
Yeah, now you can, yes.
So let me tell you that there is an interesting correlation which we have seen that almost 95% of the patients who presented with symptoms of mucormycosis, they were in the end of second week or the third week of their getting COVID infection. So we traced all these patients from the first day of the symptom and the time when they got their RT-PCR test and when they got their RT-PCR test negative. So all of them have presented to us within 4 weeks. None of them have got this mucormycosis after a passage of a month, number one. Number two, the first symptom with all of them came, as told by Dr. Rajiv Gupta, is headache. Most of them had some heaviness on one side of the face. It was not a uniform, diffuse headache. There was a little bit of heaviness. They will not feel comfortable in the area of the eye. It's something which is irritating you, number one. Number two, two patients, we came to us with a little bit of swelling underneath the eye, which was a just mild swelling if you compare from the contralateral side, which was healthy. None of them actually I have seen to come with epistaxis, which has been mentioned like a bloody nasal discharge or this. Now, the beautiful thing which we are doing, all these patients who have recovered from COVID, who are known diabetic, pre-diabetic, who have been admitted to the hospital or not admitted at home or who have taken steroid and complain of these symptoms, we have called them to the OPD to do a nasal endoscopy. Now, nasal endoscopy is being used as a screening tool. And Dr. Dhawan, you will not be surprised that slightly bluish discoloration of the mucosa of the middle turbinate of that side before it becomes like a black HR thing, which we call as a diagnostic of a mucormycosis. Seeing that color of the mucosa, we took a nasal swab in from two patients' nose where we could see a little bit of pus coming out from the middle meatus, and we could get a KOH sampling done, and the result came in about 30 minutes, which showed classical broad aseptate or pauciseptate hyphae with right angle branching. Three patients had symptoms of little heaviness of the eye and little bit of headache. And when we did their endoscopy, we could see a little bit of discoloration of the middle turbinate, but there was no discharge. There was no pus, there was no fungus. These were the patients where we got their CT scan of the PNS, and there is an article in American Journal of Neuroradiology which has laid emphasis on a non-contrast CT, certain factors which could help you in diagnosing mucormycosis. If we suspect eye symptoms like any blurring of vision, any swelling of the eyelid, or any ptosis or signs of ophthalmoplegia, definitely a MRI is to be done. But yes, a nasal endoscopy, a simple nasal endoscopy in the OPD, we have been able to catch 90% of the patients with confirmed diagnosis of mucormycosis in the OPD with KOH stain.
Great. We'll come back to the prevention part again later on, but let me go to Rituraj now. That what are the eye symptoms which are seen in these patients when they present?
Hello, am I audible now?
Yes, I can. We can hear you.
Hello. Yeah, what I have seen in most of these cases, like this time, is first of all like a headache, which is like around the eyes. Some says like yeah, definitely there are lots of false alarm, but like those people who are positive, either it's a swelling, but what I've seen, a lot of people have come with a absolute ophthalmoplegia with the ptosis, and they suddenly says like the ptosis had developed suddenly overnight, and it's there. Plus, the movement of the eyes are restricted. There was one patient who came down with a diplopia. He was very specific. He said like, when I look up, I'm seeing double. So and congestion, but most and diminution of vision is also one of the major cause. One of the and sign that I have encountered till now.
So since his network is a little poor, so let me just rephrase it or summarize it for the sake of the audience, that in the eye, a dull ache or pain around the eye is a common symptom, which is part of the headache on one side. Heaviness below the eye is another symptom. Some irritation, vague discomfort are there. Blurring of vision happens a little later stage. There can be doubling of vision, that patient sees a double image of the same object, especially a vertical doubling, And by the time more severe symptoms present, it's already a little too late, which can be the form of droopiness of the eyelid, loss of movement of the eyes, bulging of the eyes, redness, congestion of the eyes, and severe loss of the vision. So these are the common ways in which it shows up in the eye. And but by the time there is a bulging of the eyes, a severe loss of vision, fungus is probably already spread to the orbit, and so it's a quite a late stage. Coming to the diagnosis, what is the way to diagnose it, Dr. Ashish?
Diagnosis is by context and very few tests. You will appreciate that a fungal culture will take long time. Dr. Mrig has pointed out that a KOH preparation in early stage, taken out from the mucosa or from the nasopharynx or somewhere, will probably be the best way to diagnose it if taken early and done early. Now, there is no serologic marker or there is nothing like that which will help you to diagnose it. And a direct examination histologically is probably the best way, for which nasal endoscopy and taking the sample directly from the mucosa is probably the best. Now, as far as the brain is concerned, I wouldn't like the fungus to go inside the brain, and because the mortality is more than 80% once it enters the cranial cavity. So it's almost fatal. And so the diagnosis is in 2-3 ways. One, of course, is the simple scan, an MRI scan, which will, there are 3 manifestations of it inside the brain, of which the commonest is a abscess formation or a granuloma formation, a mass lesion. So the mass lesion will be picked up on a scan, number 1. And if it is if you need direct confirmation, because if there's no other site where there is mucormycosis and you want to take it directly from the brain, because then the treatment changes. So if it is a large lesion, then the diagnostic and therapeutic way is to just excise it as early as possible, because I'm sure all my colleagues will agree that a surgical debridement is the fundamental cornerstone of treatment. It is the cornerstone. The treatment, of course, is pharmacological, but the cornerstone of management is surgical debridement, however you achieve it. If it is deep-seated, then you can do a stereotactic biopsy, and then you can get a confirmation. However, let me just reiterate that in the current context where we are having this, 300 cases or 200 odd cases from Dr. Mrig, and I'm sure there are all our colleagues all over the country who are having cases and maybe reporting at some point in time. If the number is so large and the context is right, then if you see a lesion like that in the brain, unless you are going to operate, or unless you are just if you are just going to do a pharmacological treatment, then you must have a confirmation in the brain, because you may be missing some other lesion in the brain because of the mucormycosis. So open biopsy or a stereotactic biopsy to confirm it, and then give excise it, debride it, and then give antifungals, which of course my internal medicine physicians will be very competent to do that. But I'm sure Dr. Rituraj and Dr. Mrig both have had the opportunity to do and would like to do as early a debridement as possible. It's a very unpleasant job to do an exenteration of the eye. You also know it. Dr. Mrig will tell you that sometimes the debridement can be quite devastating inside, leading to problems. But I don't think you should delay that, because the next thing that is going to happen is going to go in the brain. Then problems will become manifold.
Very rightly said. So, of course, we'll be talking at length about the treatment part, but a very important question which I'd like to pose to Dr. Rajiv Gupta, that when there's so much talk about black fungus, there's also a lot of panic amongst people, especially the ones who had COVID in the past. And I'm getting a lot of calls, people who suspect that they've got black fungus and mucormycosis. Many times we cannot see the patient physically. There are online consults. So, what are the pointers on an online consult which a physician can pick up and which lead towards the possibility of mucormycosis, and those patients you have to call them for a physical examination?
As I told you, we have to go by the clinical presentations, how the patients are presenting. Now, a patient who has recovered from COVID, who has been a diabetic, whose sugar have soared high, say 500, 530, this is what is happening. Even if they are non-diabetic, given steroid, sugar goes up to 500. Most of the patients have HbA1c in the range of 11, 12. So many of them may not be knowing that they were diabetic. In fact, 40% people do not know that they were actually diabetic. It's only after development of COVID, the diabetes is unmasked. Secondly, even people who are not diabetic, they have steroid. So any history of uncontrolled sugar, anytime in the past 2 weeks, 3 weeks, is a very important pointer. Now, secondly, symptomatology suggestive of mucormycosis, as just explained. A unilateral headache, pain in the eyes, or a ptosis, or a bulging of the eye, or blooding, or diplopia, those things, or a nasal blockage, a discharge from one side. Those are the symptoms that one can always ask proactively in this patient whether they are actually having it or not. Right? Any suspicion of doubt, any suspicion, kindly go ahead and do CT or PNS at least. CT PNS is required. There's no harm in getting it done, and there are signs present on CT PNS which are suggestive of mucormycosis. Given that, one can do a KOH preparation, but this is also having a lot of false positive and negative. So we need to have a tissue diagnosis. That should be in the form of some kind of biopsy, either a CT guided biopsy or a direct endoscopic biopsy, or biopsy from whichever place. You have to show invasive fungal hyphal disease. That is fungal hypha, which are typical of mucus, and finally cultures. Now, mind you, culture this takes very short time. It is not a long run process, only 3 to 5 days. You culture it on seborrheic agar. Within 5 days, there is a profuse growth of fungus. Right? This is a fungus which grows very fast. So even culture can be done without any problem. Seborrheic agar is a very simple system. So you and on a room temperature we see it's 25 to 30 degree. You will easily grow this fungus. On a potato agar fungus, very simple media can grow this fungus. So no harm in doing that, because culture defines the species also, what kind of species you are dealing with. So for epidemiological reason also we might need it. Now one is a blood test. PCR, a real-time PCR test is being developed. It is being used in other country, which is very specific and sensitive for picking up these cases. So that would come up in India also. I'm sure somebody will develop it here also. So PCR test is a very important test and non-invasive test, which we can always offer to these patients where we are suspecting fungal disease, right? So short of that, at least a PNS, X-ray, or more importantly, a CT scan of the PNS is an order whenever you suspect it.
Great, sir. So coming to the treatment part, and as Dr. Ashish pointed out, that the cornerstone of treatment is the debridement, which is usually falls first in the domain of the ENT surgeon. So Dr. Mrig, can you elaborate on the treatment part? How do you decide on the treatment and what do you do?
So if a patient who has recovered from COVID and he suspected diabetic, symptoms suggestive of mucor, Or we are also getting patients with acute sinusitis who are also presenting to us and thinking like it is mucormycosis, because acute sinusitis will also present with symptoms of headache, symptoms of unilateral orbital pain. But then, as I said, uh, when we examine these patients and we see the endoscopy picture, if we are able to see the bluish discoloration or the black HR, that by itself is a diagnostic of suspected mucormycosis. Like Dr. Rajiv sir said, what we do, we take the sample in the OPD, we make the patient wait in the OPD. In 30 minutes, we get the KOH report. The culture, if it is taken from the representative and the right side, is generally diagnostic of mucormycosis. You get a classical aseptate or posiseptate hyphae with right angle branching, and they are broad septae. Once we have a diagnosis of mucormycosis, the next investigation is CT scan. And if we suspect orbit and the brain involvement, we also get a gadolinium enhanced MRI done. Now, I will just tell you what is the reason of getting an CT scan and an MRI. Now, there have been a literature available which says that erosion of CT, which is not corresponding to the amount of disease present in the sinuses. Now, generally, there is no bone erosion in the CT in normal cases of sinusitis, but a perisinus inflammation and erosion of bone can hint you that it might be a mucor case, number one. Number two, when you get a gadolinium enhanced MRI scan, the areas where the fungus has grown has caused endothelial damage, entered into the blood vessel, and devascularized that area, which has become black. Now, that part of the tissue does not pick up on MRI scan because it's a dead tissue. So, if you see a turbinate which is not enhanced, which you can't see on an MRI, and it appears like a black structure, then you feel that, then you are sure of it that mucormycosis has affected this area. Now, places where the beyond the bony structure, we have soft tissue areas like behind the maxilla, we call the pterygopalatine area. There is soft tissue, we have the pterygoid muscles, the medial pterygoid, the lateral pterygoids. If the tissue is involved there and you don't get an MRI and you plan such cases for debridement, then you will miss that area because that area is behind the maxillary bone. So, out of the 13 cases which we have operated, you will be surprised that two of the patients who had where we had nothing to take a sample from the nose, we just had the symptoms, the history of COVID, we had their diabetic status. We could not take a KOH sample because there was no pus, there was no fungus in the nose. But when we got their CT scan done, there was isolated unilateral sinusitis that too just restricted into the maxillary area. In fact, they had a little bit of uneasiness on the infraorbital rim. And when I opened that cases in the maxillary sinus, we saw fungus going underneath the eyeball on the infraorbital wall till the zygoma. Classical mucor growth was seen there, and we did a big middle metal enterostomy. We cleared the fungus, we did an enterostomy, and today I did a little advanced approach, what we call as a Denker's approach, where we do a medial maxillectomy endoscopic so that the entire maxilla from all the walls, anterolateral, posterolateral wall, you can remove the fungus. So if the patients they come early, then just a simple debridement of that area and rest of the job is done by IV amphotericin B. IV amphotericin B is the drug of choice, which is, we will talk about it. It is generally available in 4 forms in the market, in 4 different formulations, which is available. Of course, the most used one is liposomal because it is less renal toxic. So
we'll talk about the drug later.
Yes.
So let us go on to the orbit part.
Just a simple sinus surgery, a minimal fess ranging to a extended fess, to ranging to a endoscopic medial maxillectomy. And I would just say one thing what Dr. Ashish said, entry into the brain. They're very surprising, except one last case what we did today, where the entire skull base was eroded and we had the disease going through the posterior table of the frontal sinus. although it was not intracranial, but it was actually extradural. 90% of all the patients we have seen the disease onto the middle turbinate, the middle meatus, the maxillary sinus, and the inferior orbital wall. Not even a single patient we have seen entering or being localized in the area of the lamina cribrosa. Although practically speaking, you are very right that fovea ethmoidoides and lamina cribrosa is the thinnest structure. They have sieve-like pores where the fungus can easily go to the anterior lobe. But we have not seen so far what we have operated. Infraorbital area is the most common I have seen, which I have seen almost in all the cases where the fungus has been.
So once it comes to the orbit or involves the eye, what is the management required there, Dr. Rituraj?
Yeah, first of all, like as Dr. Mrig had explained, what happened is it starts in the like the nasopharynx, and then it enters into the sinus, and then it goes way up into the orbit, and that is the point, that because that is the barrier to the brain, to be very frank. So we have to observe that particular area, but because exaggeration is the ultimate thing, it's very destructive. So we don't want to take out the eye because okay, like the cornerstone, as you can say. But taking out the eye, it will be permanent. To see like how it is involved. Like if we see only the medial part and extraconally, there is a little bit of inflammation with some kind of fungal ball, as you can say. Like then what we do is like, okay, we can give retrobulbar injections with debridement under antifungal amphotericin that way. But if we see like the all is involved, cavernous sinus is showing sign or a little bit of cerebritis, then there's no way out. Like we have to just take out the entire tissues so that like at least the fungal load goes down, and we can do some kind of everyday dressings with an amphotericin so that like and that's the whole thing.
Right. So since the network was poor for Dr. Rituraj, let me summarize it for the sake of the audience. That in early cases where the disease in the orbit or the socket of the eye is limited to a small area, we try to remove that diseased part and apply the antifungal drugs into the orbit, hoping thereby that those drugs will work and take care of all the spores there, and we'll be able to salvage the eye and to vision the vision to some extent. But in case it is extensive, in case it's reached the apex of the orbit, in case it is threatening to go into the brain, or the whole of the orbital structures are involved, then there's no way for us to save the eyeball. We have to sacrifice the eye and all the structures alongside it. So everything that fills the eye socket is removed and blocked. This is what is called by the term exentration. That whole of the contents of the eye socket are removed with the aim of removing the disease with it, and so that the drugs can work in the areas which are not yet affected by the virus, by the fungal ball. Coming to the medical management of the drug therapy of the disease, Dr. Rajiv, can you tell us in detail that what is the plan for that and how it is managed?
See, as far as management is concerned, obviously it is a surgical debridement, extensive surgical debridement, and follow-up surgical debridements. Not only once, you may have to follow it with more endoscopic evaluation in surgeries, and of course, along with a small portion that is taken care of by antifungal agents. The antifungal agents which we are using are amphotericin B, as rightly said, the 4 formulation. We are comfortable using liposomal form, which is ambisone, or there are 3-4 more available, but they're quite costly. Other is desoxycholate amphotericin B, which causes more febrile reactions as well as more nephrotoxicity. That's another problem. Though it is cheaper, that is cheaper. Other drug which we use as a salvage drug is posaconazole. Posaconazole comes as a suspension or also as a tablet form, which is the long-acting tablet form, and an injectable form that is recently available. So posaconazole is again broad spectrum antifungal agents similar to amphotericin B. Mind you, amphotericin B is also broad spectrum. It is effective in Aspergillus, Candida, Fusarium, and others. Right? So these are broad spectrum, and many times we will have a combination of disease. Like it may not be only mucor, it may also be associated with Aspergillus along with this, because many of the patients are neutropenic. right? So there, these are broad spectrum drugs which will take care of other drugs, whether we are not diagnosing or not diagnosing. So amphotericin B, we are giving generally for a period along with surgery for 5 to 7 days, generally. But it depends on the degree of removal of fungus. How much eradication of fungus could be affected by surgery. If a complete eradication has been done by surgery, we may just continue it for 5 to 7 days, followed by posaconazole, oral posaconazole. This is a routine management of these cases. This is a very costly proposition, mind you. Amphotericin B is in fact not available. An earlier part, last week I tried to get it. I could not procure it for one of patient. Since the last 1 week, I have seen 4 or 5 patients tried to treat one early, very early, by using amphotericin B. I could not get it. In fact, within few hours to next 12 hours, patient deteriorated very fast. Whatever was a local infection suddenly became eye involvement. So I had to send the patient immediately to a nearby hospital for surgical management rather than thinking of giving amphotericin B. So these drugs are good, but they will not take care of this disease. You have to do surgery along with this, and regular follow-up after surgery. So drug may have to be given for even up to 3 months, right? Initially amphotericin B, followed by month, 2 months or 3 months of posaconazole therapy. Extremely costly. Many people who are already depleted of their funds by COVID management, I don't think they can afford this, and we have to find a way out how to do this in these cases.
Yeah, that is one of the very saddest part, that the drugs are not available, or they suddenly become very expensive, and they have taken the black market route also. So all those evils are showing up. I think this, philosophically speaking, this virus is supposed to teach us a lesson which we still have not learned. And the surgery is devastating, mutilating. The treatment is expensive and prolonged. And what is the prognosis or outcome after all this treatment is done? Dr. Ashish?
I think Dr. Rajiv wants to say something.
Please. Yeah, please, Dr. Rajiv. Yes, go ahead, sir.
Unfortunately, most of the patients die. Patients who have pulmonary involvement, which I will just like to correct. You said pulmonary involvement is uncommon. There is a problem in diagnosing pulmonary cases. Already we have ground glass opacity, and the earliest presentation of fungus is also ground glass opacity. Right, formation of some ill-defined consolidations. Again, you see in a lot of cases of COVID pneumonia having this. So diagnosing separate from the COVID pneumonia is always a problem. However, we have seen 1 or 2 patients who are going on to developing nodules. Once they start developing nodules, we start suspecting this is not COVID. This is something looks like a more fungal disease. So we are trying to get, but unfortunately, most of the patients die before we go for anything further. We plan to go for bronchoscopy, but before we plan bronchoscopy, patient dies. They are very quick deaths. We do not know how to save these patients. They die very fast. So second thing is, what I was telling about prognosis. Prognosis mortality is very high. Even after best of treatment, 46% people will only survive. More than that is 50% will die despite whatever we are offering. And patients who are disseminated, 100% deaths. Patients who have pulmonary disease, 75% will die. So very few people will survive, and whoever will survive with a blind eye, with a deformed face and things like that. A very unfortunate situation. So one should rather try to prevent if it is preventable rather than treat. Treatment is very costly and gives you very poor results.
Yes, the treatment leads to a lot of disfigurement. The fatality rate or the mortality rate is very high. As Rajiv said, that more than 50% is the fatality rate in this disease. So the best option that we have at our hand is actually prevention. So that brings us to the main part of our talk. What are the ways to prevent? Dr. Sumit, you had started talking about prevention. So let us go further in the direction.
I think the biggest factor which I think this disease can be prevented is strict glycemic control, because sugar is going to be a food for the fungus, and if we can ensure that patients who are recovering from COVID, if they can maintain their glycemic control absolutely under limits, then the chances of this disease getting disseminated and spreading inside the nose, the rhinoorbital or the cerebral can be limited, number one. Number two, let's identify at-risk patients. If somebody has got severe lymphopenia, then I think we should not wait. We should correct that. Meet your physician, talk to them, granulocyte stimulating factors, or it can be given, and you should correct severe lymphopenia. Especially, I would say that all of these patients who have been discharged, what we have done at Max Healthcare, we have given them handouts now. This handouts mentions about warning red signs, red flag signs, that if they are recovered from COVID, they are diabetic, they have received oxygen, uh, if they get this 5 or 6 symptoms, the red flag signs or symptoms, they should immediately report to an ENT surgeon for a nasal endoscopy. Like Dr. Rajiv said, whatever you do, at the end of the day, we will not be able to save more than 40% because the presentation is very late. At the end of the day, we can only save, and let me tell you, about 8 to 9 cases which we have done, I was glad in a way that we could remove the disease from the sinuses. The disease has not entered the orbit. So early identification, immunity boosting, early glycemic control, strict glycemic control. If you are immunocompromised, meet your physician to improve your lymphocyte counts. Then, and red flag signs, handouts to be given all to the patients so that they reach to you on time. But I agree, there is hardly any drug available in Delhi. The drug is now being controlled by the Delhi government, and we have no option but to debride and at least get them rid of the bulk fungus in the nose and the sinuses.
Dr. Sumit, you talked about the diagnostic endoscopy. Do you think there's any role of just a screening endoscopy at the end of 2 weeks and at 3 weeks post-COVID?
I would say that not for all of them. Giving them handouts, the red flag symptoms and the signs, the moment they feel that they have got any of these symptoms, they should report for an endoscopy. See, we can't do a blanket nasal endoscopy for everyone. But yes, one more thing, I told you, majority of the data of 200 patients is between 50 to 60 years of age. Majority of them. So maybe that age we have to be very cautious about.
And also you said males, 80% are males now.
Yes, 80% are males.
Is there any predisposition for the right or the left side?
So far I have seen more on the left side.
Yes, I have the same opinion that more on the left side, and I have yet not been able to figure out that why left side is more affected in a lot of diseases, not just this disease, but there are a lot of other diseases where the left side is more affected than the right side. Or Ashish, do you have any hypothesis for that? Things like cavernous sinus thrombosis, things like orbital varices are more common on the left side.
I was smiling when you were saying mostly on the left side, because the one patient with cranial intracerebral involvement I have seen was entirely on the right side. Right temporal lobe pole, right side of the brainstem, right eye involved. However, I don't think I would like to proffer any hypothesis regarding the predilection for the left side.
Just a wild guess.
Wild, I don't know.
Things like rhabdomyosarcoma, things like orbital varices, things like cavernous sinus thrombosis, now the mucormycosis, are seen more commonly towards the left side than on the right side. Left eye gets a very, very bad or bad share of the things. It's very poor deal.
I would hesitate to put any kind of hypothesis to it, and I think. But I would certainly say one small message to the patients as well as to the doctors. In the current context, when we are all sitting down in this webinar and everyone is aware of the very high incidence, I think an equally high index of suspicion is required. First thing is that there should be no hesitation in calling an ENT person or an off-orbit person to come and see the eye and the nose. Even if you don't suspect anything and you are feeling that something is not right, I mean, you can just say something is not right, a nasal blockage, a simple sinusitis. Dr. Mrig said that some patients are coming panicking because they have a sinusitis and they think that it's black sun. I'm glad they are coming before they develop it. So the message I want to give is a very high index from the side of the doctors. Number two, a message to the patients. Yes, exenteration of the eye is a very bad procedure, very disfiguring, functionally very bad. debridement inside the nose can lead to a lot of long-term problems. Intracerebral, suppose if there is a thing which treated with pharmacologically gets all right, but late onset mycotic aneurysms of the middle-sized arteries in the brain can happen. So I think the patients should agree to a very early surgical intervention. We have this tendency ki, surgery. Dr. Mrig says I have to take out the medial wall of the maxilla. Dr. Rituraj, yourself talk about exenteration. I say that we might have to open up the skull for a temporal lobe lesion. There is a huge resistance from the patient and the public. But we all agree that that can be life-saving. A simple endoscopic debridement at the stage when it is just involving the middle meatus is probably good, or just the medial wall of the orbit, before it comes to me to sort of, apologize to the patient's relatives that, sorry, we can't do anything. So the two high things I would keep as priority are high index of suspicion and high agreement from and consent from the patient side for a surgical intervention, because that's what ultimately will save him. Long-term results, yes, medicine and all sorts of treatment, but that is only for final treatment, not for the early immediate response.
Very important messages for the doctors and for the patients, you said. Now, Rajiv, what are your final messages for everybody, for the audience?
So my point is, let us control diabetes well. That is a very important single factor which is going to change the scenario if we really want to change it. Control diabetes. Always do blood sugar wherever patient is diabetic or non-diabetic. That is what we are doing. All patients, we are doing 8-hourly blood sugar, irrespective of their diabetes status. Right? Whether they are receiving steroid or not. I particularly feel that steroids have been labeled as a villain, which may not be actually true. As rightly said, we are using steroid for such a long time. For lupus, I've been using it for years. For other conditions, we're using it for a long time. Interstitial lung disease, we are using for years together without any problems. It is not purely steroids and also not oxygen. Kindly do not make it a villain. See, patient cannot live without oxygen. If we are giving a message why oxygen is causing it tomorrow, they will refuse to take oxygen and die because of hypoxia. Right? So oxygen is not a villain, mind you. Even industrial oxygen has not been shown to grow spores, grow the fungus. They have not been shown. They have put petri dish on the against that flow of that oxygen from the industrial cylinder. It has been done. No fungus has been demonstrated even in industrial source, right? So do not label oxygen as a villain. It is a life-saving thing for the person who is having hypoxic respiratory failure. That's number one. Secondly, control diabetes at all times. And mind you, do not try to control diabetes with oral agents. This is the biggest mistake people are doing at home. It has to be controlled by insulin, only insulin, and strategically given insulin. We have to control most of the hyperglycemia. So strategically given insulin, try to see that sugar remains within 140 to 180 range, not 500, not 400, not 300. These people are going to land up with other problems, not only fungus, even white fungus. They will have more of aspergillus, more of candida, particularly candida. Do not forget, the initial results, the reports were of candida auris from the All India Institute of Medical, 25 cases in the last epidemic. So do not forget about the other fungus also. They are equally important. Control diabetes well. Do not stay away from steroids. Steroids are life-saving in most of these patients. Their steroids are life-saving, but give them properly at proper doses and for a proper duration of time. Right? Normally we say up to 10 days, but it may not be sometime possible to stop steroid at 10 days. We have to extend it for another few days because patients are unable to perform their routine activity without hypoxia. What do? There's only one thing is steroids. All other things are bullshit. They don't work. So steroids should be used carefully, properly, but they are not the villain. And in fact, I doubt whether corticosteroid should be called a predisposing factor for mucormycosis. Should be. They should not be. Frankly speaking, there is always an element of doubt in labeling them as such. So control diabetes, control diabetes, control diabetes. That is the only message.
Very important, very strong message. Very well taken. Dr. Rituraj Barua, what is your final message for the audience?
What I would suggest is actually we are definitely getting lots of false alarm, but still it's I would suggest if there is any kind of signs, any kind of facial changes, pain or it's abnormal, it's better to get it checked rather than sitting and being more optimistic towards it. That I
Right,
would
so
like to
very
say.
rightly said. Yeah, very rightly said. And because the poor network here, I'm sure the audience could not hear it. So let me rephrase it for the audience. The message from Dr. Rituraj is that if you feel any suspicion of any signs, any symptoms, it is better to err on the side of consultation rather than ignoring it and letting it delaying the diagnosis. So, Dr. Sumit, what is your final take-home message for the audience?
I would say that every sinusitis is not mucormycosis. And yes, if you have someone in your family who do you think falls into the at-risk category, please don't think twice before visiting your ENT surgeon, because you can only save a life if you detect it early. The second message is this is a time of, again, a teamwork of an ENT, an ophthalmologist, an internal medicine, an endocrinologist. Together, if we work properly, only then we can save and prevent the spread of the disease to a very devastating nature.
Great, fantastic. That's a very good message. That's time for the teamwork where the physicians from various specialties need to come together and work together on our patient. There should not be any hesitation in doing so. Thank you very much for joining us in today's show. So that brings us towards the end of the show today. And from me, the final message for the audience is that mucormycosis is a very severe complication of COVID, let us say. So the most important is to prevent it. And the best way to prevent it is to prevent COVID itself. Prevention of COVID is much easier than prevention of mucormycosis or the treatment of mucormycosis. Wear your mask, wear double mask, maintain social distancing, use hand hygiene, stay at home. Don't go out. Don't let anybody come home. Go out only when it's absolutely essential. You get to hear all these messages from the government, from the media, from the doctors on how to prevent. Take those steps. Save yourself, save your family, save your friends. That is the first step. And of course, maintain a healthy lifestyle. If you're diabetic, if it's a family history of diabetes, get yourself investigated, treat that. It's very important to maintain a good immunity and good glycemic control. And in case you develop any symptoms, any sign, do not hesitate in meeting a consultant, getting yourself checked up, getting yourself examined. Do not say no for the early treatment. The treatment may come in the form of a surgery. It may be a mutilatory surgery, but surgery is in your benefit. It is a life-saving surgery. So do not say no to the treatment, as Dr. Ashish emphasized. So this is the message which you must take home. And again, repeating, at the bottom line is try to prevent COVID as far as possible. Thank you very much. We'll come to see you again next week, same time and same place on Dr. Dhawan's live chat on Abhi TV. Thank you.
Thank you,
Bye-bye.
everyone.
Good night.
Thank you.
Namaste.
Thank you.
Thank you.
Thank you, Dr. Ashish, sir. Thank you, Dr. Rajiv Gupta, sir.
Thank you.
Thank you, Dr. Dhawan, sir. Right. Bye, Dr. Rituraj. Good night. Thank you.
I welcome all of you to IBM TV and to this show, which is Dr. Dhawan's live chat, and I'm your host, Dr. Sanjay Dhawan. I'm an eye surgeon practicing in New Delhi. The live chat is a show which talks about any and all aspects of life, any subject, anything that concerns the life or it improves its quality is what we will be talking about. How to plan for it, how to prepare for it. So we'll be talking about all of this. Looking forward to seeing all of you every Friday night, 9:30 p.m. to 10:30 p.m. Indian time. Thank you. Bye-bye. Namaste.